For a patient to meet criteria for major depressive disorder, they require at least 5 symptoms to be present for at least 2 weeks. One of the symptoms needs to be depressed mood or loss of interest or pleasure. Other symptoms that can be present include poor concentration, low energy, feelings of worthlessness or guilt, psychomotor changes, sleep changes, appetite changes, or recurrent thoughts of death or dying. It is important to note any specific thoughts of death, their frequency, and if they have a plan, and whether the patient has any intent to act on their plan. Symptoms cannot be due to a substance or medical condition, and the patient cannot have a history of manic or hypomanic episodes. Appetite can be patient-reported or objectively measured as greater than or equal to 5% weight loss in 30 days. Psychomotor changes should be objective and observable by the interviewer and documented in your mental status exam. There are quite a few specifiers for major depressive disorder, and here we will cover some of the more common ones you will encounter. The with psychotic features specifier means the patient is experiencing delusions or hallucinations. Typically, they are mood congruent and negative. For example, the patient hears voices telling them they are worthless and should die, but they can also experience mood incongruent psychosis. The with anxious distress specifier means they have symptomatology identical to generalized anxiety disorder. However, symptoms have not been present for greater than 6 months. The with mixed features specifier means the patient demonstrates 3 or more symptoms of mania, but does not meet criteria for a true manic or hypomanic episode. Symptoms must be observable by others and a change from the patient's baseline. Documentation of observations in the mental status exam would be important here for symptoms such as pressured speech and grandiosity. Lastly, if a patient is hospitalized, it is most likely a severe major depressive disorder. We use this specifier if the symptoms are particularly disruptive to a patient's functioning, they're extremely distressing, or if they have symptoms substantially in excess of the minimum required.
There are several other diagnoses you may want to consider when thinking about MDD. For example, an adult patient might qualify for diagnosis of persistent depressive disorder if they have depressed mood most of the day, for more days than not, for at least 2 years. It's also possible for a patient to have both persistent depressive disorder and MDD. In premenstrual dysphoric disorder, the depressive symptoms typically occur at a certain time of the month, corresponding with a patient's menstrual cycle. You may also encounter patients with substance or medication-induced depressive disorders. If a patient's currently intoxicated or under the influence of a substance, you should reevaluate the patient at a later time to get a better history. If the depressive symptoms only occur in the context of the specific substance or alcohol, you should consider substance or medication-induced depressive disorder as your diagnosis. In the context of grief, a patient may also have comorbid major depressive disorder. If criteria are met for MDD, MDD should be one of the patient's diagnoses. You might also encounter patients who are in the hospital for some sort of secondary gain. So in this case, you might want to pay close attention to the patient's history and other potential benefits of staying in the hospital for them. There are also multiple medical reasons a patient might present with depression. They're not discussed in detail here, but it's important to keep this on your differential as well. And after some sort of severe life change, a patient might also present with depressive symptoms. So it's important to gather a full history from the patient. Patients with bipolar disorder can also have depressive phases. And if the patient's not currently manic or hypomanic, you can diagnose bipolar disorder and specify that the current episode is depressive. If the patient's currently manic or hypomanic, you should diagnose other specified bipolar and related disorder until you can gather more history from the patient or collateral information. Patients with borderline personality disorder can also have comorbid major depressive disorder. If a patient with a known history of borderline personality disorder presents inpatient or to the ED with a recent suicide or self-harm attempt, your diagnosis might initially be borderline personality disorder and adjustment disorder with depressed mood until you have some more information and timeline of events. If a traumatic event has occurred and the patient meets criteria for MDD and either acute stress disorder or PTSD, you can diagnose both. It's also important to ask the patient about suicidal ideation or thoughts about harming themselves. Sometimes patients might not be forthcoming at first, so you want to make sure that you keep asking questions until you have a better understanding of what is specifically happening. Make sure that your questions are direct. For example, you can directly ask them, are you having thoughts about killing or hurting yourself? Do you want to kill yourself? Do you have a specific plan of how you would kill or hurt yourself? And when asking, sensitive questions like this, you want to make sure you're making direct eye contact with the patient. Don't be looking at your computer or typing while asking these questions. You also want to pay attention to how the patient's responding to your questions as far as body language and nonverbal communication goes. Do your best to be non-judgmental as well. For example, questions like, well, why do you want to die? Why do you want to do this to yourself? Might not be the most helpful at this time. With all of the information, you can make a risk assessment. So some higher risk scenarios include if a patient has just attempted suicide, if they attempted suicide, are currently denying it, but collateral information says otherwise, or if the patient has prior suicide attempts. And with all of this information that you gathered, you'll need to decide whether the patient is safe for discharge home with outpatient follow-up, or if a patient requires inpatient management and treatment for their safety. If you're talking with a patient and they really don't want inpatient management, but you believe that this is one of those high-risk scenarios, make sure to tell the patient that you think inpatient management is the safest option at this time, and make sure that you tell them why as well.
A useful tool for addressing suicidality is the patient safety plan. Typically, these are done by psychology or social work. We will not go into detail about a patient safety plan, but in brief, they assist a patient with identification of warning signs prior to going into crisis, utilize strategies to cope with suicidal ideation, provide options for social support, provide resources they can utilize, and gives them strategies for making their environment safer.